His name is Dr. Feel Good in the morning.
Cheers, my fellow ophthalmologists and glaucoma specialists. This is Dr. Victor Flores from Merida, Mexico. This is my first recording experience since I left residency about 7 years ago. So I do apologize for the technical flaws that were present in this video, which will be corrected in my upcoming releases. I decided to present this case because it was a rather interesting scenario of a 37-year-old female with herpetic glaucoma, very high IOPs, around 40 millimeters of mercury of mean IOP, but significant nocturnal peaks of about 60 as measured with home tonometry, with, of course, maximum tolerated medical therapy. I decided to start the case with a phacoemulsification of a very soft lens, as would be expected for her age. The IA probe was all it took to get rid of all the nucleus material, as you are able to witness. However, I must mention that there was significant posterior pressure being exerted on the capsular bag, so that made it somewhat tricky to get rid of all the cortical material. But if you proceed with patience and cautious, there is absolutely no problem with it. I decided to leave the subincisional material for after the implantation of the intraocular lens because it felt already too risky. There was really not much space in that bag. After filling up the bag with cohesive viscoelastic, I was able to implant the lens in the way you would expect, although there was not a small amount of contraction involved in the maneuver, but eventually we got there. The single piece acrylic lens was implanted in a normal fashion, and afterwards the rest of the cortical material was able to come out without any complications. After the lens implantation, we proceeded to fill the bag with even more viscoelastic and to perform a gonyosinechiolysis with a maneuver that I learned from Dr. Ayala in Cataract Coach a couple of weeks ago, in which you exert radial traction with the capsulorhexis forceps, taking care not to disattach the iris root, of course, and rewardingly so, the pupil came down very nicely, so we assumed that the gonyosinechiolysis was done. I don't typically favor closing my incisions with nylon after cataract surgery, but I believe this case was warranted because we do not want to incur in any hypotension during the implantation of the glaucoma drainage device. We removed the viscoelastic, which is very important because you want to be able to check the flow from the tube after you implant it. We went ahead and closed the incisions properly to make sure there was no leak, and afterwards we injected the lidocaine epinephrine solution and made a peritomy in the way you would expect in the superotemporal quadrant of the eye. This patient, since she was so young and given her skin type, had a very thick tenon capsule. But if you are trying to insert or to implant a drainage device behind the muscles, you must dissect. You have to be careful, of course, not to damage the muscles. This is the traction suture, the silk, 6-0 silk, going into the cornea so you can pull the eye. And as I said, you have to dissect. This patient had also a history of strabismus, so we assumed that her muscles could be inserted in an atypical fashion, so we proceeded with a lot of caution. The diathermy, the cautery, was performed as you would expect in a case like this, just to obtain the necessary hemostasia. And you have to remember that a feature of the Powell glaucoma implant is that it needs absolutely a 6-0 prolene inserted into the lumen to be able to regulate the flow. You have to go all the way behind the muscles, of course, so there is a hook that needs to be used. both in the superior rectal muscle and the lateral rectus muscle. You have to make sure that the valve or that the plate is all the way back there. It still needs to be mobile, but not so much that it would come out upon traction. Now, please pay attention to this other trick that I learned in videos, that you could apply an additional traction suture on the tenon, and this would help twofold. Number one, it will open the field for you, so you'll have more of a view. And number two, it'll help you prolapse the eye a little bit. Now, please pay attention to the way that we try to fixate the plate. This is something else that I learned in Cataract Coach a couple of weeks ago, in which you use the same 6-0 proline to fixate it, and afterwards you want to cut it in a short segment and then apply more diathermy, more cautery, to create those bulbous tips as you would in a Yamane fixation or any other scleral fixation that involves proline. This saves a lot of time instead of making the knots, and it also gives you the advantage of allowing the plate to be a little bit mobile and not completely stuck in the same place. After you are going to try and insert the tube into the anterior chamber. In Mexico, we do not have scleral patches available to us, so I decided to create a scleral flap in the same way that you would for a standard trabeculectomy in a normal fashion. I open it with a crescent and then with some Vanna scissors, I cut it into the length that is appropriate and insert it not towards the center of the pupil, but more radially towards the center of the iris stroma. We use a 25 needle in order to insert this tube. It's a lot slimmer than the tube of the Ahmed valve, in which we typically use in Mexico. You close the scleral flap like you would in any other surgery, and you make sure that the tube is properly placed against the iris and not towards the cornea. It is very important with the Paul glaucoma device that you check the flow rate. You have to make sure that there's enough liquid coming out of the eye, but not too much. You have to count. Ideally, the normal pace is about 5 to 7 seconds per drop of water. That is 1 drop of water or aqueous every 5 to 7 seconds. If you have more than that, you have to insert the proline further into the lumen, and if you have less than that, you have to pull it up. The rest of the proline you can leave subconjunctivally, and you can remove the slit lamp later. Afterwards, you have to close the conjunctiva in a normal fashion, and the surgery is pretty much done. Please make sure to check the tone of the eye after you're done, and if you want, leave a little viscoelastic to prevent hypotony. Thank you very much for the attention to this matter.